Hi, this is William Henderson.
And this is B. McGraw.
And this is the Unjerked podcast. So the Unjerked podcast is a podcast where we talk about different things which are commonly discussed on websites like Reddit and Twitter. And we take a closer look at what's really going on in terms of what the data says about that topic. So we're going to wrap up our episode on healthcare costs. On the supply side, so there is the supply of doctors is lower than it should be in the U.S. So the Government Accountability Office has an article on this: physician workforce caps on Medicare-funded graduate medical education at teaching hospitals. But essentially, a resident is basically a doctor who finishes medical school and then spends a number of years basically in training under the supervision of other doctors, right? In practice, it's actually a bit tricky. So residents are usually less productive than attending physicians just because they're less experienced.
Yeah, I'd imagine so.
Yeah, and they have to be supervised. And so that, there's the salaries of the other doctors who are basically helping them out that gets factored in. So even though residents get paid less than full-time doctors, they actually are less profitable for hospitals, and oftentimes without subsidies, they're a cost to hospitals, and so it's actually quite problematic. And so to deal with that, the government subsidizes residency slots. So residency slots, there's a lot of payment that Medicare basically provides to hospitals for residents. The problem is in the 1990s, as part of a budget balancing negotiation, they decided to freeze the number of residency slots. And so for the past, almost 30 years, basically the number of residency slots has not been going up.
Oh, really? Like there's
yes.
been the same amount of residents than there was 30 years ago?
Essentially.
What?
The number of yeah.
What? That's crazy.
Yeah.
What on earth?
So
I'm assuming like that also means that they have to, limit who goes to medical school too because of that.
Yeah, so the bottleneck is residency slots. And so there's no use in increasing medical school slots because this is the bottleneck. The residency afterwards is the bottleneck. There's some hospital-funded residents, like this Government Accountability Office graph does show, there are some hospitals that pay for it directly. But as a general rule, like it's hard, the money, the numbers usually don't work for hospitals unless the government subsidizes it. And so, this is like, when I first read about this, I was like, there's no way this is true.
No, that doesn't sound right at all, but wow.
Yeah.
What?
And, whenever you restrict supply, what does that do? That increases prices.
Yeah.
So in the case of doctors, it increases their salaries quite a bit. I tried to do an analysis.
They are crazy overworked.
Oh yeah, for sure. So I tried to do an analysis because American doctors, they get paid more, but they also have more student debt and they have to pay more liability insurance. So I tried to play around with the numbers, and I could, I never got around to finishing this, but what I found was even after accounting for student loan payments and liability insurance, American doctors still make quite a bit more money than European doctors, for example. So I know it depends on specialty. Certain surgery specialties, they get paid lots more money. So it depends. But generally speaking, doctors do get paid more in the U.S.
Yeah, I've always
there's
heard
also
that.
A certificate of need laws are another way supply is restricted. So basically, they're in place in 35 states. So not all 50, but most of them. And it requires healthcare providers to obtain a certificate of the economic necessity of building a new hospital or a new expansion. And the rationale for this essentially was that there would be induced demand. If you just build more hospitals, then more people will try to get treatment and it'll increase expenses. The analysis basically says, so it says the literature, and this is a meta study. Did I say the title of this already?
No.
Okay, it's Certificate of Need Laws, a Systematic Review and Cost Effectiveness Analysis by Christopher Conover from Duke University. Center for Health Policy, and James Bailey from Providence College. But this is a meta study, but their analysis, it says literature provides mixed results. On average, finding certificate of need increases health expenditures and overall elderly mortality while reducing heart surgery mortality. Not sure why. It also estimates the costs of con laws somewhat exceed their benefits, although our estimates are quite uncertain. So this isn't, this is probably less of an issue, but it's still, I just don't really understand. I just don't buy the argument that somehow having too many hospitals is a bad thing.
No.
Yeah. My perspective is like, if somebody, if a company, if, Subway wants to build a new franchise location in some area, like it's on them, if there's no demand there, like that's on them. But generally speaking, businesses are pretty good at estimating demand. So they'll know whether it's a Starbucks or a Subway or, a Barnes and Nobles or whatever. Like usually they do that analysis and say like, is there enough demand at this location to build a store there? I don't see why a hospital can do the same thing. So I think that the idea that you need, and so a lot of times there's only one certificate of, for certificate of need laws, there's like only, in a given location, the state will basically say like, all right, this hospital is like allocated to, the position of being the hospital for this particular area. And then like a second hospital is not allowed to be built, nearby. And I just don't think it makes sense in my mind, at least. And then finally, admin bloat in hospitals. So this is a very substantial issue.
A lot of people talk about this.
Yeah.
This is a popular thing to blame.
So
people love hating on admin.
So Center for American Progress, which is a think tank, it says excess administrative costs burden the U.S. healthcare system. But essentially, these costs typically are tied to things like billing. So billing and insurance-related costs. There's excess administrative costs in general, administrative costs for payers. So if you look at a comparison of systems, so what percent of healthcare spending in the U.S. is administrative? So in the U.S. it's 8.3%. In France it's 5.7%. Ooh. And then if you get all the way down to Norway, it's 0.6%. And so most other peer nations range from 0.6 to 5.7% of healthcare costs. So we
significantly have a large admin costs.
Yeah, and a lot of it is related to basically the complicated health insurance system, where different procedures have to be coded to certain. There's officially government approved codes for different procedures, and there's work involved in like figuring out which code applies to a specific procedure. And then there's the back and forth with the insurance companies. And there's a lot of like administrative stuff that does not exist to the same degree in other countries. And so that's just pure waste in my mind. In other countries, the government negotiates prices for different procedures. And then, the doctor basically says, all right, this is what I did. I, did this surgery. And then the price is already determined. And so there's just much less administrative, bloat tied to that, tied to payments, tied to insurance, etc. And I think this is very problematic because this is just pure waste. It's just unproductive behavior. Other issues. So we do have an unhealthy lifestyle in the U.S. Part of it is unwalkable cities due to zoning laws we discussed before in a previous episode. And then also there's subsidies for perhaps unhealthy foods. So there's an article, consumption of food derived from subsidized crops remains associated with cardiometabolic risk by a bunch of people. But this was published. Is this the name of the journal? Nutrients? I guess that's the name of the journal. But basically, they said, it says the proportion of calories derived from subsidized food commodities continues to be associated with adverse cardiometabolic risk factors.
That seems like a no-brainer.
Yeah. Though the relationship with obesity and abdominal adiposity has weakened in recent years. I haven't researched food subsidies a ton. I know there's a certain logic behind it. I think the idea with subsidies is to ensure there's always a safe food supply in case of war or whatever. And
Mm-hmm.
staple crops are typically easier to store and they're more calorie rich. And so you can make an argument they're more important to have in wartime. Um, but the research seems to indicate it contributes to health issues. You know, aging population, we talked about this already. The impact of population aging and public health support on EU labor markets, International Journal of Environmental Research and Public Health. But it kind of goes over different economic outcomes tied to an elderly population. So as this balance shifts in favor of older people, productivity tends to suffer on the one hand, and the older group demands more health services on the other hand. You know, it's a thing. Rural
Yep.
healthcare. So this
That's
is
a
sort of
tricky
like
one.
this is an aside. So Government Accountability Office says why healthcare is harder to access in rural America, and it talks about the distance you have to drive to get to inpatient care, to alcohol or drug misuse treatment facilities. There's just fewer doctors, etc. And that's kind of like because if being a doctor is like an ultra prestige industry where people make, depending on the specialty, like they could make, well, let's say like if you're a primary care doctor, I'm assuming you're making like, low to mid, probably lower six figures, I'm assuming.
Mm-hmm.
If you're doing a specialized surgery, like some doctors could be making like getting close to like $1 million a year.
Yeah.
And how, does being in a prestige career really jive with living in a rural area, living in a farm town in Missouri or whatever? Because usually people who make tons of money, they want to live in big cities, right? So how do you square that circle?
I mean, also in between insurance and paying off your debts, you're like, oh, well, I just do a little bit of city work and then you never leave.
Yeah. There's a discussion about private equity. So Harvard Medical School, what happens when private equity takes over a hospital? New analysis shows alarming increase in patient complications. So they talk about
I haven't thought about that.
some issues with quality of care that can arise after a private equity firm buys a hospital.
Like what?
Well, so there's multiple different strategies to private equity. One is roll-ups, where you try to increase economies of scale by buying up smaller businesses. One is revenue synergies revenue synergies, where you're basically trying to cross-sell different services to new customers that you bring on. So let's say you're an existing company and you buy a new company, and the new company's product you can now offer to your existing customers. So the idea is you can increase efficiency with revenue synergies. The other is cost synergies, which is a euphemism for, oftentimes laying people off or closing down facilities. So let's say you buy another company, or you buy two companies and they have redundant IT systems. You can lay off a bunch of the IT workers, for example. And so, the lower outcomes, it's probably tied to just trying to cut expenses, like reducing staff count, et cetera. And so, let's see if there's specific details. So after a hospital was acquired by private equity, Medicare patients had a 25% increase in hospital-acquired complications, 27% more falls, and 38% more bloodstream infections caused by central lines.
Oh.
Yeah.
So they got sloppy.
Well, I think essentially I think the mechanism of action is that they buy a hospital, and you don't, like private equity firms, they don't just buy an asset and just hold on to it, because it's like anyone can.
Yeah,
do
they
that.
try and
like
make more money off of it.
Well, the whole point is you're trying to find a way, like the theory behind private, because I do think private equity has a place in the economy for sure, because what they do is they buy struggling businesses. Either they buy a small business that has potential but needs cash to scale, and they'll just like inject a ton of resources into it, or they'll buy a company that's struggling and basically like whip it into shape. They'll like fire the old CEO and like get rid of redundant expenses, etc. But in the context of hospitals, it gets kind of tricky where, you know, what if the way you increase returns is to like reduce staffing or, you know, reduce other expenses?
Yeah.
It seems like it could cause problems.
Mm-hmm.
A few solutions tied to what we talked about. So, could we reduce vendor economic surplus, vendor profits by negotiating drug prices? Could Medicare negotiate drug prices? That seems like a no-brainer to me.
I think that's a no-brainer. I'm glad that we're at least starting to do it. I can't believe we didn't even do that till last year.
Yeah, for me, it's just a no-brainer. Increasing healthcare supply. So can we have some sort of automatic way of adjusting residency slots? Because we're using the same numbers as the 1990s.
Yeah, that's nuts. I still can't believe that's true.
Yeah, could it either adjust automatically, or could there be a non-political, you know, board of advisors who determines the annual number each year? Could we remove certificate of need laws so that we can increase the supply of hospitals? This one, this next recommendation, I might be talking out of my element. But is there a way to kind of do accelerated MD programs? So I know in the UK, there's an option for people to go straight into medical school, essentially, because I think in the US, so you go to college for 4 years, and then I think medical school is like, is it 5 years or is it 3 years?
It's somewhere between 3 and 5. I cannot remember.
Yeah. Okay. So you go to college, you know, you major in something pre-med or biology, or, you know, there's a bunch of, you know, potential majors, and then you go to medical school after that. In the UK, there are programs that allow people to go straight into a sort of hybrid program where you basically do the pre-med stuff and then you go into medical school. So it's kind of a direct to medical school program, and it's I think the total number of years is like about 1 year less than if you do like college plus medical school. Not sure if that would really make a huge difference.
I don't know. Like, if our doctors can't do literary analysis of Moby Dick, it could just completely fall apart.
I mean, yeah, you need a society where people can talk about, you know, revenge fantasies related to whales, you know,
or whatever else.
So reducing waste.
Things you're learning.
So one way you can reduce waste is have a more streamlined billing and coding system, which is easier to do when you have a single payer system. Unfortunately, so mandatory insurance was struck down by the Supreme Court. So the original ACA, there was actually a tax penalty tied to if you basically opted out of having insurance, you had to pay a fee.
I remember hearing about that.
And it was basically a way, and the Supreme Court shot it down. And I think the argument essentially was that it was unconstitutional to force people to pay for a product or service. I don't remember the exact argument. Pay for value. We talked about that already. You know, can we continue transitioning to that system?
How many people are uninsured in America?
I think it's like I think it's like 5 to 10% now or something. It used to be much higher before the ACA.
Oh, probably. Yeah. Well, pre-existing conditions, and
that was another big issue.
That was a huge issue, and if you are, that probably made insurance more expensive because, as we mentioned, that death spiral. But I think didn't it make it way more affordable for people at lower incomes?
Yeah,
and that was like the big thing. Because, like, I don't know, did you ever try and get insurance through the ACA marketplace or whatever it's called?
Not through the ACA, no.
If you make money, it's pretty expensive.
Yeah.
It's at the point where it's just you start doing that calculation of like, how often do you think I'm going to go to the emergency room for something?
Well, typically, if you're unemployed, you could I think you can get Medicaid, or maybe not. It depends on how much money.
If you're unemployed, it's not bad, but it's like if you're self-employed, it's a lot.
It's tough if you're self-employed, and also like if you work for a company, you probably have a company affiliated program. And it's just so much cheaper than whatever is on the market. because
the company insurance is always super cheap, but if
because
you're
the company probably
self-employed or you're a gig worker, it's pretty bad.
It's pretty bad. But the company,
especially if you make a bunch of money.
Yeah, because the company will usually pay for like 3/4 or something of your
it's a lot.
premiums. And that's why like it's not even a free market in my mind, because practically speaking, the insurance you use is the one your employer provides. Like you don't really have a choice. And most people, they don't have the flexibility of life circumstances to just job hop all the time. Like it's usually like, oh, well, like I have a family to take care of and I have a job and I'm not going to risk that just to get a different insurance.
Yeah.
Can we maximize patient health? So we already talked about value-based care. So the impact of value-based payment models for networks of care and transmural care, a systematic literature review. But let's read the abstract. So the conclusions, overall positive effect on clinical and cost outcomes validates the success of VBP models. So their results say value-based works.
How would you measure value-based?
So essentially, you benchmark. There's different methods, but essentially, you take in a patient and you find some way to benchmark them. It's like what is their background in terms of their health, their level of health, their demographics, and then you provide treatment, and then do they get better? Do they have better, through different metrics of their whatever problem they had. The reason you want to benchmark is because like if you don't, then you'll just like end up rejecting like super sick people, because it's like, oh well, if I'm judged based off of like how well the patient ends up being, well, I'll just like only accept like super healthy patients. So obviously you have to benchmark it against their actual health levels. I don't know the details, to be honest.
Yeah, well, I'm wondering how like the business model of a value-based care works. Like, because if you're not charging them for services, is it just like insurance pays for everything?
Well, like let's say like the
like how does this
doctor
work?
I don't know, like let's say the doctor provides services and then it just like doesn't work, and he's just an incompetent doctor, and the patient is worse off. Well, like the insurance company could probably say like, why would I pay you? Like you made my patient worse. Like you didn't do anything. You just worsened their situation. So why should we pay you anything? So I think that's like a sort of the basic idea is like, I will pay you more money as the insurance company. And also insurance companies want healthy customer. Like insurance companies want their patients to be healthy, because insurance companies are the ones that pay for everything. And they don't want to pay for things, because the more you have to pay out, the less money they make. So they want people to be healthy,
Yeah.
No,
the insurance companies are definitely in favor of people being healthier.
Yeah. There's a couple other things tied to this. Integrated care models. So like, it's usually not as good when like the different specialists you have don't talk to each other. So it's better, like, let's say someone has some issue. It's like, well, there's surgery involved. There's like, they have to go to like physical therapy. They have to take medication. They have to like go to, therapy. Like, how do we kind of combine that in a way that maximizes outcomes? And how can we coordinate care across different specialties? Primary care, obviously, like primary care, expanding that is good because you can catch problems earlier, etc. Are there ways to do task shifting? So task shifting is essentially, so human resources for health. Does task shifting yield cost savings and improve efficiency for health systems? A systematic review of evidence from low income and middle income countries. So this is a meta study. Their conclusion, task shifting presents a viable option for health system cost savings in LMICs. And then it talks about a bunch of things. So it seems to be, assuming it's done correctly. So task shifting is where you take tasks that a doctor, it doesn't have to be a doctor to do it. So instead, maybe you could have a nurse practitioner or a physician's assistant do something. So here's an example, providing a vaccine shot. You don't even need a physician's assistant for that. You can just go to Walgreens, right? You can just show up to the Walgreens and have an appointment and just get your vaccine. So it makes no sense to like talk to an actual MD in order to get your flu vaccine. It's a total waste of
No, who does
resources.
that anyway?
Well, nobody does, but that's an extreme example. And so
Yeah.
like are there things that doctors don't need to be the one doing it? Maybe you can have a nurse
You got
practitioner or a
those,
physician's
those
assistant.
nurse practitioner lines are always great.
So some of the counter arguments, I mentioned these at the start, so I won't go over these a ton. One argument is we don't have good healthcare because we fund the military too much. That's irrelevant because we already spend more on healthcare than other countries do. So other line items in the federal budget, they're not the issue. It's a complete red herring argument. Sort of the right wing arguments. So forcing someone to buy a product is tyranny is kind of the argument. I disagree with this. Well, obviously, if the government tried to force you to buy like, I don't know, Beanie Babies or something, I would consider that like serious government overreach. But here are some comparisons. Auto insurance is, functionally speaking, a mandatory product in this country.
Yes.
People used to say, well, people used
you
to say,
don't have to drive.
well, they would say driving is a privilege. Functionally speaking, in most of the country, if you don't have a car and if you can't drive, like you are screwed. You can't get groceries. You can't, like, you know, hypothetically, could you just do Instacart and, you know, what it's like maybe, but like
There are
you have
a bunch
to drive.
of people that do that now.
You have to drive to work though, and most people there's not enough public transportation to get to work without a car. And so essentially you can't go to work, you can't get food, you can't do anything without a car. And also the reason why most cities are not walkable is because of the government creates laws that make them unwalkable. And so functionally speaking, the government, like auto insurance is mandatory, at least at the household level. Social insurance is also mandatory. You have to pay into Social Security. You can't just say, "Oh, I'm good." You can't be like, "Oh, well, I'm not going to pull out of Social Security. I'm like, I'll waive my right to Social Security later in life, so I'm not going to pay my payroll taxes." Like, that's not how it works. You have to pay it, or you go to jail, right? Same with elderly health insurance. We call it Medicare in the U.S. You cannot opt out of paying into Medicare. You have to pay into it, assuming you have a job, obviously. K through 12 education is a mandatory product. You can't just, you can get approved for homeschooling, but like you can't be like, oh, like my kid's not going to get educated. Like you would get arrested if you did that, right? And so quite a few products are actually, in fact, mandatory in this country.
Yeah. But I mean, also, like, I think the issue is like, since hospitals operate under the Hippocratic Oath, like if you go in without insurance, like they're going to help you out, and like you could just not pay eventually. So like, or if you're found like, passed out on the side of the road, like you're going to end up in the emergency room of the hospital, whether or not you're paying for health insurance. Like, yeah, it probably should be mandatory.
Well, I just think, the tyranny argument, I just don't buy it, because there's already so many things, because we're paying more for health stuff. We pay higher premium, like when you combine taxes. So we pay taxes for Medicare, we pay taxes for Medicaid, and we pay premiums on our personal health insurance, and we pay deductibles when we have an expense, and co-pays as well. When you add all those things together, we pay more for healthcare than other countries, other peer nations do, and we get worse outcomes. The idea that somehow reducing that expense while getting better outcomes is tyranny, I think that's just a ridiculous argument. I think it's absolutely ridiculous. And also, I think the thing with tyranny is like it can happen at multiple levels. Certainly, the national government can be tyrannical. We see that a lot with a lot of dictatorships. But local governments can also be tyrannical, and private interests can also be tyrannical. When you look at slavery, that was mostly upheld and advocated for at the state level, and advocated for by private interests, by people who own slaves. And so I think tyranny can happen at multiple different levels across multiple different types of entities. And so there's nuance when you talk about that, you know. So government-owned healthcare will be used to install, a Marxist, you know, government. That's just never how it's never happened that way. There are plenty of countries in Europe. Most countries, frankly, have universal healthcare, and they don't necessarily have to be government-owned hospitals. You can have systems with privately owned hospitals, and most of those countries, they did not. They're still democracies. So the idea that somehow this will lead to dictatorship, it's just not. Like when you look at historical examples, it's just not the case. And the way countries become communist is through Marxist parties basically basically overthrowing governments. That's how it happens. It doesn't happen through healthcare. It's just a completely ridiculous argument that does not have actual historic examples attached to it. The death panels argument, I think when you just, because people said that a lot back in the day when ACA was up for debate. And just look at the outcomes in the US versus the EU and East Asia when it comes to, how many times do people end up succumbing to medical conditions because of poor healthcare. You see much more of that in the US than you do in other countries. Like I said, health outcomes are worse in the US than in most of Europe and in East Asia.
Yeah, and especially since like because everyone knows how expensive it is, even with insurance, I think a lot of people unnecessarily avoid any healthcare until it's like way too late.
Yeah, and then
so it's just a lot of the freebie stuff doesn't. Just like the stigma of health insurance being expensive is almost making it worse.
And then some people might say, the sort of like hyper libertarian argument is like, why should I subsidize someone else's healthcare needs? That's their problem. And I think you could say that about you could say that about Social Security. You could say that about Medicare. You could say that about like women's shelters. You could say that about buses. Like at a certain, to a certain degree, taxes don't equally provide services to the same degree you paid into the system. That's just kind of how it works. And also, sick societies have negative externalities. People are less productive. There's more poverty. There's more crime, etc. Counter arguments that are sort of correct. So one is that taxes would go up. So that's true, probably. But the flip side is overall expenses would go down because you're paying fewer premium. You're paying less in premiums and deductibles. So when you look at healthcare costs per capita, according to the Peter G. Peterson Foundation, the U.S. pays, and we saw a similar graph earlier. U.S. pays $12,000 per year per person. Switzerland $9,000. Italy $4,700. So we would pay less overall. Wait times is sort of correct. So
I heard that one a lot.
So healthcare reform, learning from other major healthcare systems, and I won't go through this whole article, but some systems do have longer wait times for elective procedures. But at the end of the day, we talked about healthcare outcomes, and the outcomes are better in other countries. So I think, and also, so overall, I just think, that tends to happen more. But overall, when you look at the actual outcomes, the United States is a much less healthy country than countries in Europe and East Asia are. And we pay more to achieve that worse outcome. So even though wait times might be longer in certain countries, I think all things considered, it's still a better system, I think. So that wraps things up. Do you have any last minute thoughts?
Well, I think there's also kind of like a vibe check that I think, or like one of the vibes I hear for a lot of this that is a little dismissive to healthcare problems is that some people would be like, well, if your health is bad, it's probably your fault, in between like diet and exercise or something. I think a lot of people use that as a way of dismissing the issue when in reality, like there are a ton of things that happen to people's health that's completely out of control.
Yeah, I agree with that. There's all sorts of diseases that can arise that you had no control over, and also a lot of even lifestyle diseases, because of city design and because of food subsidies, we create an environment that encourages unhealthy behavior.
Oh
And
yeah.
theoretically, you could say, you should have the willpower to resist that, but I still think that has to be taken into account. And also, like I said before, bad health is not good for society. It
No.
makes society less productive. And so it's not good for us collectively to have a lot of sick people. All right, so that was our final episode on our series on healthcare costs. We'll go on with another topic next time.